a lot of the care coordinators would understand is about the self-management. And lastly is using digital. So using some tools that allow patients to do bits and pieces for themselves from home or even in surgeries without actually having to book an appointment with a GP or any clinician for that matter. So that's the principles of the proactive care pathway. And you would know, you'd understand a bit more as we go along. So the next slide, please, Paul. Thank you. So this is what I hope you're going to get out of today. And it seems like multiple outcomes, but really it's understanding the stratification and how we are, dividing them to low, medium, high risk, understanding targets, looking at a bit more personalization of care and what are the key components of that, understanding what Q risk is, calculating it. And this is particularly for the HCAs that are seeing these patients, understanding the concept of non-compliance, what are your local resources, the red flags, and related to that, when do you refer? When can you refer patients? So I hope that covers kind of most of the areas why you think you're here. But if there's anything else that you feel that needs to be covered, by all means, add it to the chat function. Next slide, please, Paul. Okay, so here's a question. And I know people that haven't dealt with patients probably can't answer or some of these, but actually just have a guess. So I want you to, Paul, do you want to explain the poll function, how you're going to do the poll here? So this is a question for all of you that I want you to answer, and hold the thought because we're going to come back to it. So this is high blood pressure check. Who needs it? Does anyone who comes to the surgery, anyone new that joins, a new patient? Any patient that's requesting it, so anybody can walk and say, I want a blood pressure check. Anyone from the age of 25, anyone with diabetes, or anyone with a family history of blood pressure. So just submit your answers. Let's see what the results show. So the question is about who needs a blood pressure check.
So just to reassure everyone, this is an anonymous poll. It is multiple choice, so
yeah,
choose whatever you feel is the right answer.
Yeah, so Sahar, if you want to click, Paul, you might just have to explain how to do the poll.
So everyone should see, I can see plenty of people are, the vast majority of people have started to respond now. You should see on your screen, I'm not seeing what you see, but you should see on your screen a question with a few answers underneath it, which relates to the slide that's on the screen. Just click your cursor into whichever or as many of the tick boxes against the answers that you feel are appropriate, and then that will come up on my screen. And then when I click close, we'll see the outcome of that poll.
Okay, so let's just give another 10 seconds, and if you want to then close this poll and then show us the results.
2 people who haven't responded yet, so
okay.
Thinking very long and hard about the answers.
Which is great. It's great. So Sahar, you've put down an answer in the chat function. I don't know if you've managed to get onto the poll. So if those 2 people, please, can you just enter your, because this will just help. I'm not looking at these results. This is for your own self-reflection. When we go through the theory bit, it's about you then seeing if actually your answers change after we've given you the theory bit. Okay, Paul, if people haven't answered, we should just close it and just, yeah. Okay.
Let's have a look. No, so can you see the results?
Yeah, I can. Yeah. So basically, a majority of people saying anyone with a family history and anyone new to the surgery, and they've, I think the least point is anyone from the age of 25. Okay, so let's just move on to the next slide, and we'll come back to this. Okay, so when we talk about who needs a check, we need to consider actually what are the risk factors for hypertension. And it's quite easy to remember that blood pressure is blood vessels. So anything to do with the blood vessels that affect major organs will be the risk factor. So people with heart failure, with heart disease, with stroke, kidney disease, vascular disease, dementia, obesity, preeclampsia. This is all the risk factors. So if you see, all these conditions can affect the blood vessels. So essentially any and everything that affects the blood vessels can cause a high blood pressure. Next slide, please. In addition, this is what NICE guidelines has highlighted as the risk factors. So this would be advancing age. One would guess that, and I'm sure you would know that. Women tend to have a lower blood pressure than men up to the age of 65, and over that, a higher. Of course, we know this, hopefully, the certain ethnicity are more likely to be diagnosed. There is some genetic factor, particularly if you've got both parents, then there's a high risk of you getting blood pressure. And actually more and more as GPs, we're seeing patients even under the age of 40 with a strong family history of hypertension. And of course, deprivation, primarily because probably their lifestyle isn't great. And that leads on to lifestyle, smoking, alcohol, diet, obesity, the lot. And as you would recognize that completely. And this one, last one, actually wasn't well recognized up until a NICE last change its guidance, and now actually recognizes the impact of anxiety and emotional stress are causing high blood pressure. And I think we all knew it all along, but it wasn't kind of in the guidance. So if you go back to the question as to who needs the blood pressure check, and actually anyone, and the people that answered sort of didn't answer the age of 25, actually NICE does say that people with risk factors, like for diabetes check, they should have their blood pressure checked from the age of 25. Okay, now in practices, and you're right, every patient that joins the practice, when I say every adult I'm talking about, should have a baseline blood pressure check, absolutely. But if you see they've got these other risk factors when you're taking the new patient health check, actually they also need a blood pressure check, not just at that time, but NICE would say every 5 years. So these patients who have not been diagnosed, they need a blood pressure every 5 years. And again, this is for the coaches that don't necessarily need and see patients, but it's just for you to be aware that actually is every 5 years, unless they've got risk factors, which may then make them have a blood pressure every year. So for example, they've ended up having a stroke, then they need a blood pressure every year. But if got the no risk factors, then they still need it every 5 years. I hope that's clear. Yeah. So next slide, please, Paul. So that was a bit about the risk factors. Now I just wanted to introduce you to some terms that you might come across when either speaking to patients or also when reviewing the records. The first one is primary hypertension. And that just, by that we mean that you've got blood pressure without any reason. So, you know, you've just got blood pressure because you're 65 and you're 70. So it's age related, or there's a genetic. So that's primary hypertension. Secondary hypertension basically means there's a secondary cause for it. So the blood pressure is caused by something. It could be a kidney problem, it could be a heart problem, but that's related to something that's causing the blood pressure. Then you've got the term malignant hypertension, which is a blood pressure which is really, really high, high enough to actually imminently require intervention, be it admission or even medication, depending on, and we'll talk about that a bit later. So it's really high blood pressure. Masked hypertension and white coat hypertension, they're slightly different terms. So masked hypertension would be a patient that comes to you at the practice and has normal blood pressure. However, when they do it at home and the other environments, the blood pressure is high. Converse to that, the white coat hypertension is when they see somebody in a white coat. So this is somebody in a practice or somebody in a clinician's role. The blood pressure shoots up with anxiety, and actually at home it's normal. So just for you to understand these terms, and most of the patient, 90% are primary hypertension. That means there's no secondary reasons for it. They've just got blood pressure because they've got a strong family history, or there's a genetic predisposition, etc. 10% are secondary hypertension as well. There is another term called drug-induced blood pressure, but I'm not going to go into that for this group at the moment. Okay, next slide, please, Paul. I'm just going to look and see if there's anything in the chat that's come through now. Okay, so another poll for you. Again, just if you take out your sort of focus on these questions. So what can poor blood pressure control cause? So this is about complications. What are the complications of poor blood pressure control? What can it result in? Why are we interested in controlling blood pressure? So Paul, do you want to put up the poll, please? I'm getting confused with Paul and poll. Okay, I think we probably time this if I give you 30 seconds. So read out the answers. Blood pressure, high blood pressure, or poor control rather, can cause stroke, heart failure, heart attacks, kidney failure, blindness.
Sorry, just a quick question. So
Sure.
is it more than one, I take it then?
You do, yeah. I mean, you could do, yeah. Paul, are we up? Paul?
Just take myself off mute. So we're up to 19. I think we're probably going to stick at 19 again. Shall I stop it?
Okay, so we've got one rogue person that doesn't want to participate.
Actually, do you know what? I'm being really silly because we have 19 participants and you and I make the 21. So
we are the rogues.
We're waiting for us to fill in our own poll.
Oh no, thank you guys. Thank you. We will get it right. Okay, Paul, so do you want to see? Yeah. Okay, fantastic. Great. So actually, so Paul, next slide, please. So those of you that answered all were absolutely right. So what can high blood pressure do? As you imagine, if you've got a pipe, you know, a water pipe, and if you pass water there really with high pressure, what's going to happen? It's going to burst, right? And so exactly what happens in blood pressure is that instead of bursting with the blood vessels, they start thickening in response to that pressure. So when they thicken, they become stiff. When they become stiff, the pressure, about the same volume of blood in a smaller area, causes the pressure to go up high. So it's basic sort of physics principles. So that's what it can do. And this is why literally every organ can be affected by blood pressure. So it can burst the eye blood vessels, causing blindness, the brain blood vessels causing stroke, the heart causing heart attack and resulting in failure. The blood vessels in the legs can cause peripheral vascular disease. So actually anything and everything, any organ with a blood pressure, with blood vessels can cause high blood pressure, can cause complications of that. And hence why we need to really control it. And the important thing is to recognize most of the patients do not have symptoms, and you'll hear it all the time. You know, 18 years of practice, and I still hear, you know, you tell somebody they've got blood pressure, no, I don't have it because I don't have any symptoms. And that's like diabetes, early diabetes, they just don't get any symptoms, where if they've got hair loss or conjunctivitis, they've got symptoms, you know, and they want treatment now. And so it's important. I just wanted to put that up because I want you to be able to explain to a patient what blood pressure is doing to the blood vessels. It's stiffening it up, and actually, depending on the size of the blood vessel, it can even burst, so causing strokes, hemorrhagic strokes. Next slide, please, Paul. Thank you.
Sorry, just a quick question.
Sure.
It might be a stupid one, but
no. I told you it's a safe environment. Ask what you have to.
So, you know, throughout we've mentioned that it's high blood pressure, but do these also get involved with low blood pressure as well? Or
so you can, yes and no. So although this is stratification for hypertension, that another ball game is hypotension, but that's not genetic. There's other reasons for it.
Okay.
But the low blood pressure can make you feel dizzy when you stand up. Yeah. And I'll talk a bit about it when I come to the postural hypertension. So just bear and you know, just hold that thought for now.
Cool.
But it's a different ball game completely.
Fine. Yeah,
different topic really.
Sure.
But you're right. It's important to be aware of it, particularly recognizing the symptoms, because they could have low blood pressure as well, sure. particularly if they're on medication. Okay.
That's fine. Yeah.
Okay, so I'm going to talk about risk stratification, which is why we're here today, really, is what UCLP have done, which is, you know, this academic science sort of partnership. What they looked at was post-COVID, how are the GPs going to manage the arduous task of dealing with not just hypertensive patients, but diabetes, COPD, etc. So what is it that we can do to bring the patients that are high risk to be seen sooner, and the low risk then can be, seen in their time, because they all need to be seen, but actually less prioritized. So what they did was they used some parameters, and I've just listed so you know what the pathway is about. They've used things like if the patient's already got a stroke or a heart disease or anything to do with blood vessels, if they're diabetic, if they've got kidney disease, or CKD stands for chronic kidney disease, and if they're overweight. They've then used the blood pressure reading and stratified them into what we call as a stratified pathway. So this is just a bit of background. You don't need to know, except that actually some of the parameters that they've used is established blood vessel problems, obesity, and blood pressure in a patient. And then, Paul, next slide, please. With that, then they've come up with this pathway. Okay, now this is where I really want you to focus and understand. You see the green bit here. The green bit is why we are here today. This is the low risk pathway. Okay, we are not diagnosing patients. Yeah, all the people that are here are not diagnosing patients. These are patients that are already being stratified based on the criteria I mentioned on the previous slide, and being put into these categories. And your PC and your practice, we need to work out a way or develop a pathway of how they call and recall these patients for you. So that's not what your role is, although it might be if your practice wants you to do the call and recall as well. But really, so this is the 4 groups. And I was talking to you about the green group. All the role of the green group people would be to see and review patient as an annual check. So you would have a patient who's already been risk stratified, has come to you, you decide if they're under 80, over 80, you've got the targets there, which are 140, 90 and 150, 90, easy to remember these, but it gets even more confusing later, but I'll talk to you about that. And then the patient is reviewed either remotely or face-to-face or both. So you could use a video consult, for example, to see how patients done their blood pressure technique. You could use a video or a phone to understand their understanding of blood pressure and to offer intervention. Obviously, that may not be possible in every patient. And for some patient with certain vulnerable groups, you're going to have to do that face-to-face. But a large majority, you could do a hybrid model. In fact, my view is most of the green work can be done remotely, the green pathway. So literally you're checking if they're compliant, if they've got side effects, if they've got a problem with the supply, is the chemist delivering on time? You then see how they're doing the blood pressure, make sure that that's been done well. And you advise them when they next need to submit the blood pressure readings and when to seek help, which is a red flag. And the only active bit that you're doing on the computer as such is working out the Q risk. And I'll talk to you about that. So hold that thought. And then once you feel actually the patient's blood pressure is well controlled, all the parameters are fine, they stay in the green group. If you feel actually, no, your blood pressure has now started to go up, or you're non-compliant, or actually I can't work out, your blood pressure is all over the place, then you shift them into either of the other groups. And the grouping and the shifting will be something that the PCN or the practice will need to work out how that works. And that's something that's bespoke to each area, which I can't interfere with. It's something that you need to take back to your PCN's practice to see how that would work. But the whole idea is actually the group 1, 2, 3 will have a very few patients. Majority of them, if we do this well, will be in group 4. So actually a lot of work from group 1, 2, and 3 will be done by pharmacists or the GPs to try and move these patients into group 4. Yeah. Is that concept clear? I'm not going to go through the other priority list because actually we are really here for the low risk pathway, which is the green pathway. Is that concept to people clear? If it isn't, I can repeat myself at the risk of putting some to sleep. However, it's important you understand what you're doing within that green pathway. Yeah. Okay. Thank you, Olivia. Thank you very much. Okay. Brilliant. Sandeep, thank you. That's really helpful feedback, actually. Okay. So if anyone, I can stay back after the meeting if people still want some questions answered and they don't want to ask now. just because I think this is the crux of why we are here today. Okay, next slide, please, Paul. Thank you. Paul, do you want to play the video here? So I just wanted to play this video just to show you how to measure a blood pressure, just so we all standardize that. Are you having problems with that, Paul?
Needs to come out for a second.
And if you can't do it, Paul, we might just share the resource. So, and I often actually use this to send to patients as well. And I've got a resource page that I can share with you that you use a lot of things later. So I'm going to just stop talking for a few minutes.
High blood pressure is often called the silent killer. That's because it rarely has any symptoms, yet it causes 2/3 of strokes and nearly half of all heart attacks. Shockingly, as many as 6 million people in the UK have it, of all ages, and many of them don't even know they have it until they're diagnosed by perhaps having a screening or when they have a heart attack or a stroke. Your blood pressure isn't something you can see or feel, but it's there in your arteries as it flows around your body, pumped rhythmically by your heart. Your blood pressure can be healthy, or it can be too low, but more often it can be too high, which puts your heart at risk. If your blood pressure is in the healthy range, this protects your heart and your blood vessels. If it's raised, your blood pushes with too much force against your artery walls and they become damaged. This leads to a range of problems, including heart failure, kidney disease, vascular dementia, poor circulation. Blood clots can also form in the damaged arteries, causing heart attacks and strokes. But the good news is that high blood pressure is usually preventable, which is why knowing your numbers is the most important first step you can take for your health. So what causes high blood pressure? Well, for some people, it may be the result of a condition such as kidney disease. However, for most people, about 9 out of 10, it doesn't have one particular cause. It may be a combination of factors, such as your ethnicity, your family history, your genes, and particularly if you're Black or South Asian descent. But the most important thing for most people is lifestyle. What you do and what you eat every day of your life adds up to what your blood pressure will be. Are you eating well? Are you eating lots of processed meals and sauces with salt in them? Are you trying to take some daily exercise? Do you smoke? And are you trying to keep a healthy weight for your size? All these things can have an impact on what your blood pressure is. There is only one way to know your blood pressure numbers, and that's to have it measured. And it could save your life. It's very quick, simple, and painless, and usually free. You can do it at the GPs, with your practice nurse or pharmacist, or with a simple bit of kit, you can do it at home. And what's more, people often find it's very empowering because you can take your blood pressure when you like, when you're relaxed at home, and it puts you in control. Firstly, measure your blood pressure at a time that's convenient for you. If it's in the morning, then do it before eating or taking any medication. Don't smoke, have caffeinated drinks, or exercise for 30 minutes before measuring your blood pressure. Sit quietly for a few minutes, get yourself in a comfortable position with your legs and ankles uncrossed. Try to be calm, still, and quiet. Make sure your arm is positioned properly. Rest your arm raised to the level of your heart on a table, desk, or chair arm. You might need to place a pillow or cushion under your arm. Roll up your sleeve, place the cuff on bare skin or over thin fabric. Turn the monitor on and press start when you're ready. The cuff inflates quite quickly, which will feel like a squeeze. If your monitor doesn't log blood pressure numbers, write them down. Take a repeat reading. The first reading is almost always high, so wait for a couple of minutes and then do it again. Then take an average of those two readings and write it down. Take your blood pressure at the same time each day as it varies throughout the day. Take your blood pressure every day for a week and then just once a month or so after that. Your blood pressure will be written as two numbers, a top number, the systolic, and a bottom number, the diastolic. The top number is the most important, especially if you are in the older range. A reading of 120 over 80 and up to 140 over 90 is considered pre-high blood pressure. You don't have high blood pressure yet, but it could rise with time, so it's good to keep an eye on it and take steps to lower it. 140 over 90 or over is considered high blood pressure, also known as hypertension. The risk of illness is notably higher, but don't panic. If your blood pressure readings are high, your doctor or healthcare team can help you get it under control. That's why knowing your numbers can save your life. It puts you in control and can help you live well for longer.
Thank you, Paul. Thank you. So I often share that video with the patient, primarily because it reminds them of the number, but also just a reminder during annual health checks about how to do the blood pressure. I panicked there for a minute because I've got another video with the same lady talking. So I thought, I put the wrong one, but it's fine. It was the right one. I should trust myself more. Okay, Paul, next slide, please. Thank you. Okay, as I've said, and I'm going to repeat, please enter your questions on the chat. I'll try and answer as I'm going along. I can stay back if you've got any questions, or just stop. Is that okay? We will share the slides, Kubra, so you can absolutely have the link for the video. Paul, if you want to take that as an action for people that have attended, we can send them the link. And I've just saved it in my browser. So every time a patient comes, I'll just copy and paste literally to AccuRx and sort of send it. Okay, right, time again to Paul. So, so this is a blood pressure diagnosis. Now, for people that aren't dealing with patients directly, the sort of non-clinical people there in the call today might struggle with some of the answers, but don't worry. Just read them and just have fun. Just answer them as you feel answering. That's fine. So this is about diagnosis. And again, although you won't be diagnosing patients, but it's important that when you're seeing patients who are non-hypertensives, for you to understand how to and where to signpost them in which group and risk stratification, etc. So in terms of the diagnoses, so the first answer is one high reading is enough to diagnose. Should be checked after 1 week if high, should be checked in both arms. Sitting and standing blood pressure should only be done if the patient feels dizzy on standing. ABPM is ambulatory blood pressure. That means that you refer them for a 24-hour blood pressure monitoring. That means they go somewhere, they get attached to a monitor that then they have to return after 24 hours. And those people then send the GP the results. Home blood pressure, which is HPB, is the monitor that you've just seen that they do at home. So home blood pressure can both be used to confirm the diagnosis. So play away and see what you think. And again, just you're judging yourself, nobody else. And 30 seconds if I can give you for that, please. Okay, so Paul, everyone answered?
Just about. We've got 18. I think we can close it.
So 19 and 20 is you and me, right?
No, 21, 20 and 21 is you.
Oh, 20 and 21. Okay, fine. So just that one person. Otherwise, let's just. Okay, so hold that thought. And actually, let's just move on because I'm going to come back to these questions later on, just see if there's been an improvement. Okay, and moving on with the same theme, I want you to answer the next two questions as well. So ambulatory blood pressure, which is what I've explained, is that the patient gets given or goes to a clinic, then they get a monitor that they've got to attach themselves for 24 hours. And then they have to return it back to the clinic, who then sends the results to the GP. Okay, so who do you actually give the ambulatory blood pressure readings? Who do you refer? Would you offer it to patients with blood pressure over 180, 120? Or if the blood pressure is between 140, 90 and 180, 120? Lots of figures, and I'm sorry if I'm confusing you, but it's really important you understand these concepts. And can refer if you suspect white coat hypertension, and only refer if you're unable to do home blood pressure readings. So who would you refer for ambulatory blood pressure readings? Again, just 30 seconds. Okay, Paul, let me know when they've answered. And I apologize for people that haven't sort of, because there's a mix of people, I had to get a bit of more theory as well.
I think we can call it.
Yep, that's fine. Let's just, and hold on to your answers. If the blood pressure between 140, 90 and 180, 120, okay, that's the topmost result. Okay, hold that thought. And Paul, let's move on to the next one.
The next poll.
Yeah, I think there should be another poll. Next slide. Yeah, and the last one here. So home blood pressure reading. When do you ask the patient to do that? Do you record 2 consecutive readings when sitting 1 minute apart? Do you record readings twice a day? Do you record for 4 to 7 days? And you discard the readings, and it should say discard first day reading and take average of next 7-day readings. So when you give patient instructions that actually I want your home blood pressure readings, what do you actually tell them? Is it that you're recording consecutive readings twice a day, 4 to 7 days? You discard the first day reading and take an average of 7-day reading. What do you do? Again, Paul, and now because you've become excellent in polls, I'll give you 20 seconds. Okay, Paul, let me know.
So we're up to 16, 17, close it there and share.
Okay, so the answer that we've got most is record reading twice a day. Okay, fantastic. Okay, Paul, if you close that and move on to the next slide. So I want you to just hold your answers and I'm going to give you a bit of theory. And as I said, we will answer the things later on again. So this is what NICE says. So NICE says when you diagnose blood pressure, you need to take 2 readings in the morning and 2 in the afternoon and for 7 days, and you calculate the average. And as you know, the average you calculate is that you take all the top blood pressure reading, the systolic, as you heard in the video, and you calculate and you divide that by 7, and then you take the bottom. So you have an average of systolic and you have an average of diastolic. But NICE says for annual home blood pressure monitors, you've got to take 2 readings in the morning, 2 in the evening, minimum period of 4 days. So actually you can get the patient to do 4 days, ideally 7 days, but 4 days as well. So similar, except the duration is slightly different, but you need 2 in the morning and 2 in the evening, simply because a lot of the trials that were done, they looked at that the first reading tends to be slightly higher. So they want to take the best of the 2 readings. So actually take this, take the second reading there. Okay, is that clear in terms of how we diagnose? Yeah, we've done the risk factors. We're now on how do we diagnose? Okay. So the question is, there's an obvious anomaly when patients give you, would you omit that from the average? It depends, Olivia, when you say what is the anomaly? Do you want to be a bit more specific? Because really, generally, the only anomaly will be that they haven't recorded. If there's a really high, suddenly high reading, I always ask patients, actually, it's been okay. What happened there? So you do tend to ask that, but I can't see anything else that would impact those. And the thing is, if you're worried, you just get them to do another day's reading. It's not a big deal. They've got the monitor at home. They just do it. But yeah, if they've missed it, you missed that day and you just get them to do, if they've given you 4 days worth of readings and actually 1 day is missing, you just tell them to do another day. Okay, thank you, Olivia. Next slide, please. Okay, so this is where NICE has been quite helpful in terms of there's various ways to diagnose sort of a blood pressure, but I just want you to understand and remember a few things. So NICE is saying you can use home blood pressure, you can use clinic blood pressure, you can use surgery reports. A lot of surgeries now have got these sort of pods where the patient can come in, put their hand in, get the blood pressure, which is linked to the system, and that gets recorded. You could also refer for 24-hour blood pressure monitor, which is mainly for diagnoses. Now, sitting and standing, and this goes back to your point about low blood pressure, Gabble. So sitting and standing blood pressure is simply because some patients, particularly diabetic patients over 80, can get postural hypertension. That means when I stand up, my body nerves and my heart nerves work well, and they will manage to maintain my blood pressure so it doesn't drop my blood pressure too much and I don't fall. However, in patients with diabetes, that can get nerve damage. In patients with 80, that naturally the nerves also age. The ability to raise the blood pressure as you get up reduces. That means these patients are at risk of postural hypertension. So when you see patients, always ask, when you get up, do you feel dizzy? And if they say yes, make sure you do a sitting and standing blood pressure. And NICE says, actually, and this is just for the clinician here, NICE would say that at diagnosis, always do left, right, and sitting and standing blood pressure. And if sitting and standing blood pressure difference is more than 20/10, that means they've got postural hypertension symptoms. Do the blood pressure next time in a standing position, okay? And if there is a discrepancy in left and right, whichever arm gives you the lower reading, you use that reading. That's what NICE will tell you at diagnosis what you do. And again, for the clinician here, just a tip for patients that have got irregular rhythm, so atrial fibrillation, you cannot rely on the electronic blood pressure monitors. You must do the manual one. So that will take away that cohort for sort of virtual reviews to an extent. You can't do the electronic because it won't measure it well. Okay, so just remember that. But this is what I want you to remember, which is in the bold here, that for diagnoses, the readings in clinic is 140/90 and higher. Ambulatory and home is just five less. So it's 135/85. That's the easy way to remember. Okay. Again, complicated, but this is the key to remember, which is where the low risk group is, that you want patients less than 140/90. If they've got a clinic blood pressure, if they're giving you home blood pressure average, you need to make sure their average is less than 135/85. Okay. Please just remember, if nothing, you need to remember this from this talk here today. Okay. Paul, can we move on to the next, please? Thank you. Again, a bit of theory for people that are clinicians. We are expected to read code hypertension as stage 1, 2, and 3. And it simply is 140/90 to 150/95, and then 180/120. So it's just a category. Just bear that in mind. You don't have to sort of remember this completely. All I need you to remember is diagnosis is 140/90 and over, and 135/85 and over. Okay, next slide, please, Paul. I've just put this in a bit of theory. Right, now I've mentioned about the targets. Okay, so this is a poll about targets. I've already alluded to it, so you should get some of these answers right. So what are the blood pressure targets? Targets are based on under 70 or over 70 of age. So it's age related. A target is less than 140/90 for all. Target is less than 150/90. Ambulatory blood pressure, again, the blood pressure that you send the patient away to do, and they come back with a monitor for 24 hours, is 145/85. So what are our BP targets? When you see a patient, what do you tell them? What is your target? You've heard about the targets before. So again, Paul, if you just put up the poll, please, for me. And again, 20 seconds. Let me know, Paul, when people have answered.
We're up to 17, so 18, there you go. Happy to end now?
Yep, okay. So let's see what that shows. Yeah, so I mean, a lot of you have said it's for all. And do you remember I mentioned that 80, so you've got two targets. One is over 80 and one is under 80. Yeah, so you are right. For under 80s, the target is less than 140/90. but it's the target, the age is 80, not 70, all right? And again, it's 5 less, so it's 135/85 for ambulatory and home blood pressure monitor in terms of the target. So it's just 5 number less than the actual target, okay? Next slide, please, Paul. So this is what I've summarized for you, is if you look at the clinic, the target is 140/90, at home is 135/85, and over 80s is 150/90, 145/85. So just drop 5 numbers down, okay? Now, I just want the clinician here to be aware that if the patient has got CKD, chronic kidney disease or diabetes, their target, particularly if they've got some proteins passing in the urine, the target may be even lower than this, because we are now using the targets for patients with CKD and diabetes rather than hypertension on its own. So for example, CKD patient may have a target of 130/70, so even lower. So I'm just telling you this because don't be surprised if the patient comes and says to you, well, actually the doctor told me, or the pharmacist told me this should be my reading. And you're thinking, actually, no, that, you know, you're happy to be 150/90, it's okay, but actually it may be lower. Okay. Now the other thing, and if nothing that you take away from here, is this red flags. So if you have a clinic blood pressure of 180/120, I don't expect people to see the signs of retinal hemorrhage. A lot of sort of GPs won't probably be able to recognize that. But actually, if you've got a symptomatic patient who's newly confused, got chest pain, headache, heart failure, kidney disease, and their blood pressure in the clinic is 180/120, that is a red flag. You send this patient in, okay? There is something, you know, they're waiting to stroke, or they're waiting to have a heart attack, or something is going to happen with this patient. So just make sure you remember 140/90, 180/120, and from the 150/90, and just drop 5 from the targets from there. But really, it's this reading that I want you to remember. And again, I haven't come across many patients, but I have some. If we didn't intervene at the right time, the patient would have had a really bad outcome. So just be aware, symptomatic patient, 180/120, you need to go and speak to the GP on site, on call, whoever, however, yeah? And in fact, when you're telling patients on an annual review, I always warn them that actually if your home blood pressure read goes that and you feel unwell in any which way, please contact the surgery. If you're not open, 111, contact somebody now. All right. So it's just something that you could use as a safety net. Next slide, please. Okay. Now I've covered the risk factors. I've talked to you about a bit of the targets. I've explained to you what ambulatory and some of the terms and the home blood pressure and the targets used for that, and a bit about the red flags. We're going to move on to something slightly different. And this will all come together a bit later. So this is a concept of cardiovascular risk. So you remember I mentioned to you that patients who have got blood pressure, they're at increased risk of vascular heart problems from the stiffening of that blood vessels, okay? So there is a new way we can now work out the risk of a patient. So that essentially means, it's called Q risk. And that essentially means, what is your risk of developing a heart attack or a stroke over the next 10 years? And there is a range for that. And that's what I want you to just answer this. Again, reflect. A lot of you, I appreciate, wouldn't even heard of it, but those who haven't know it, please do attempt this. So this is about Q risk. You use this to decide a statin use, which is a cholesterol lowering tablet use. This is over 15% is high risk, needs to be only done once, can be worked out using Q risk formula on a calculator. So it's basically using a calculator, and you just take your calculator and work it out. Can you do that? So if Paul, can I have the polls, please? Okay. So 20 seconds. I should have gone for 10 seconds actually this time. 20 seconds. And if you just answer what you think. And just have a go for people, just have a go. As I said, just whatever, and you might just be right. That's one thing with MCQs, isn't it? Okay, so Azra, the question is about Q risk. What is Q risk? Do you use it to decide a cholesterol, whether to start patient on a statin? Do you consider 15% high risk? Do you do Q risk only once? And can you use the Q risk? Do you use a calculator, your normal calculator, use the Q risk formula and add it to your calculator and work it out? Is that slightly clearer, Azra? So it's about how do you calculate Q risk? Yeah, and I appreciate that, Azra. If you haven't used it, it'll be confusing, but I'm going to talk about it in a second because actually it's really easy. So have a go at what you think is the right answer. And then Paul, let's just close the polls because I want to move on to the next slide. I'm just conscious of time. As always, I've yet to complete a webinar on time. Okay, so it can be worked out using, so that's the one that you've on your calculator. Okay, right. So Paul, just if you close this one and move to the next slide, please. Okay, actually, so Q risk, you don't have to do anything because on EMIS, there's a template. All you need to do is to click onto that template and it works it out automatically. So for those clinicians that are going to be doing the low risk pathway, the expectation is that you work out the Q risk on a patient every time. And actually, it is really, really easy. And one of your tasks from today would be actually to go back to your practices and ask your GPs, nurses, whoever to show you how to work it out. It's literally 2 clicks and the system works it out for you. You don't have to take a calculator, do anything. And if the patient's Q risk comes as over 10%, they get offered a statin, which is a cholesterol lowering tablet, because what that cholesterol will do is if you've got a hardened artery, what happens is that there's a risk of the platelets, which causes the clots essentially sticking onto these hard walls. So the statins will actually dissolve some of those clots. So actually you need a statin to reduce your cardiovascular risk. Okay. And if the patient, if you've done a Q risk, you don't have to do a Q risk for patient already on a cholesterol tablet. Okay. Which is where that question was, do you always do it just once in lifetime? So if the patient's on a statin, you don't have to bother. Don't worry about it. If the patient isn't on a cholesterol lowering tablet, you must do it. And if there aren't, you go and speak to a clinician because that patient needs a cholesterol tablet. And this is part of the low risk pathway. Next slide, please, Paul. Okay. Now, when you see patients, this is the other bit that you need to do to work out if they've got end organ damage. Now, which is where when you do an annual review on a blood pressure patient, you do a Q risk. So you work out what their risk is. You do a urine dipstick to look for proteins because high blood pressure can damage the kidneys. Mota, there is also on every GP system, there is a Q risk template. So you just need to know where that sits and just show your team to how to do it. But equally, if you go to British Heart Foundation, I think the only system that doesn't have is TQuest, which I think there's only one practice in the whole of Redbridge with that. Then then you can actually just go on the British Heart Foundation and do it. So it's really easy to do. Okay. The other thing you do on an annual check is look for proteins in the urine, and proteins are because it tells you that the kidneys are getting damaged. So when I talk about end organ damage, that means a patient who has got no symptoms will start having some damage to their organs without knowing. And on an annual check, it's our responsibility to check to see if that's happening, because a lot of these patients can be put on medication that will reverse the damage. But primarily, we can actually be alerted to control and lower the blood pressure, because that's the only thing in these patients that is causing that damage. So you look for proteins. You do ECG. It's not every year, but you do it at baseline. So when they get diagnosed, everybody gets an ECG to see, has the blood pressure already damaged their heart? Then you look for the back of the eye. And for those people that don't have the ability or the skills, can refer them to the optician. Opticians are pretty good at checking that. And I definitely, because actually I think I'm quite good at checking the fundi, but in an environment where I haven't got the right light, and I can't really appreciate it well, I normally send them to the optician to get their annual eye check done. And then you do the blood test to look for the end organ damage. Okay, so you do diabetes check, you'll do cholesterol, And HDL is part of the cholesterol. You do USNEs, which are kidney functions, and eGFR, which are kidney functions. Okay, so that is what you do to look for the annual for the end organ damage annually when you see the patient. And again, a lot of information here. I'll just amalgamate it in a second, so it'll all make sense to you. Okay, next slide, please, Paul.
Just a quick question in the chat.
Fundus is back of the eye. Yes, thanks, Kaleem. I should have had you as my sidekick today, Kaleem, isn't it? Okay, so this next poll is about blood pressure, and I've alluded to it already. So hopefully you should be able to answer this one. So during an annual blood pressure review, so when a patient comes to you for the annual check, what is it that you're looking at? Okay, compliance, are they taking the medication regularly? Do you revisit the targets? What is it that they think the target is and what you think the target is? Blood test for cholesterol only, smoking status, and a urine test. Okay, so 30 seconds if you just answer that. And I've told you some of the answers already, so just, this should be easy, this one. Let me know, Paul, when.
So we're up to 16. Last 5 seconds. Oh, there you go, 18.
Okay, so I'm glad the blood test for cholesterol got the lowest score. So great. So as I've mentioned, definitely you'll visit the compliance, you'll visit the target. But blood tests, as I mentioned before, for kidneys, liver, you'll check the cholesterol and the diabetes. Smoking, definitely, because that's another cardiovascular risk, and the urine test. So great, thank you. Thanks, Paul. Go for the next one, please. Next slide. Okay, and again, this is guidelines. This is what NICE tells you. When the patient comes to you, every year you check the blood pressure, whether you do it at a clinic, you do it at the pod at the surgery, or you home, and you check technique, which is where the video comes in. You do a BMI, because again, this is looking at the cardiovascular risk factors. Obesity will increase that. You do the blood test, and I mentioned to you what blood test. You check compliance, you check the side effects, you revisit the diet, smoking, personalization. And personalization, by that I mean that if you've got a patient and you say to them, actually, really obese, can you go and reduce your weight and come back and your blood pressure will disappear? That is a very doctor-led agenda. So you need to personalize the care, and actually you just say, actually, I've looked at you. The main problem appears to be your weight. Let's just see how we can support that. Let's just have smaller targets, and see you regularly. And that's what we mean by personalization, rather than saying, actually, your blood pressure has go away, should be this, I'm going to increase the medication, finish. That's not personalization, because actually that patient might go home and say, well, I'm too busy working. I can't really go for, a half an hour walk every day, or whatever that is. So you need to know the lifestyle and see what works for them. And of course you discuss targets. Okay. And next slide. There is one thing missing here, which is urine. I just wanted to put this here because this is what the QOF requirements are. Every practice is required to maintain a blood pressure register. And out of that, you get points. And you can see the points and the targets here on the last column. And it just gives you, you've got to maintain a register. The target is 150/90, slightly different to the NICE targets. So it's slightly a bit more lax. Okay, so it's 150/90 for everybody essentially. And then the last bit is that you've had a blood pressure, as I mentioned to you, every 5 years, those patients that have not been diagnosed as hypertension, but they've given an age here, 45. Okay, this was just for information, so you know that some patients would, or when your practice talks to you about the QOF requirements. And that's where the alerts come onto your clinical boxes on the side. Next slide, please, Paul. Okay, now this is a question for you all, and please use the chat function to tell me, because I've told you already, cardiovascular risk reduction. What factors will reduce the risk in a patient with blood pressure? And the second bit to it is, where can you refer and signpost patients locally? So please use the chat function, speak out if you need to. I just want to spend a couple of minutes here just to understand that, what I've been talking about for so long is actually understood. Otherwise, You don't want me to repeat it all again. So anyone? Kaleem? It's nice. It's not nice to know me in these meetings because I love picking on people. Kaleem? Healthy lifestyle. Yeah, low salt. Fantastic, Kubra. Very, very well done, Kubra. So low salt. Yeah. Low blood pressure. Statin is excellent, Kubra. Brilliant. Diet, exercise. Yeah, Azra. Really, really good. Blood pressure checks. Smoking cessation. Exercise. Yeah. Obesity you mentioned. Yeah. Fantastic. Yeah, that's it. And where can you signpost these patients? Any local services? Kaleem, very good. Exercise and prescription. I hope you're all aware that there is a scheme for exercise and prescription. Low fat diet, especially if you've got patients with diabetes and blood pressure and they're obese, they can now be referred to the low calorie diet. Not everybody's part of that pilot yet, but it will come. It's called LCD, low calorie diet. And of course, our lovely health and well-being coaches, absolutely. Absolutely. And that's where the personalization bit comes in, isn't it? Motivational. Yeah, absolutely. Smoking. Yeah, brilliant. Gosh, my job here is done. That's brilliant. And pharmacy, absolutely. Smoking cessation. You've got the, obviously the social prescribers. I don't know if there are anyone's on call, but they would have access. If you're not sure, speak to your social prescriber who would know where to send these patients. Yeah, absolutely. Manu, we don't really put enough emphasis on that stress factor, but actually we should really be doing, and the health and well-being coaches here would recognize that how important it is, that well-being, the whole thing about well-being. Yep. Brilliant. No, I think, Paul, that's been covered. So I'm not going to go through that again. So next slide, please, Paul. That's brilliant. Thank you all for your responses. That was brilliant, really. And again, I've just put here what NICE is saying is essentially what you guys are saying: BMI, smoking, low salt, reduce caffeine, limit the alcohol with whatever the recommended limit is. And I always share this leaflet with the patient about high blood pressure from BHF Foundation, because it really is written in a patient-friendly sort of language. And it just really signposts to what they can do, and there's other resources then they take them into. So it's a really useful leaflet, and I think actually on there it comes in 3 or 4 different languages as well, which is really helpful, which is what we need actually in our area. Okay, brilliant. And yeah, that's fine. Next slide, please, Paul. And this is that diagnosis and an annual review as well that you'll talk about lifestyle. I wanted the, I'm not going to go into the details of the side effects, because actually it's more for the priority groups 1, 2, 3, but just so you are aware, the common side effects the patients may mention, which you may then need to signpost them to the clinician, is the drugs like amlodipine can cause ankle swelling. Very common with ramipril to have a cough, a dry cough. The beta blockers can reduce their pulse, so they may feel a heart sink kind of feeling. And the diuretics, as the name sounds, they make you go to the loo often. So this is commonly something patients I find would mention to not just clinical team, even to some of my admin team. They will come and mention, oh, I'm having ankle swelling, or I'm having a cough. So just so you're aware, I wanted to put those sort of side effects there. But nothing that you need to intervene and do, except that actually be aware and signpost. Next slide, please, Paul. Okay, I just really quickly about personalization of the care. So when I say personalized care, Dr. Ola, are you here? I wanted to just run through a sort of a demo with Dr. Ola. Dr. Ola, are you here?
Oh, yeah.
You are? Hello?
I can hear you, yeah.
Okay, Dr. Ola, we can't hear you very well. I don't know if it's just me or...
I can hear you.
Can everyone hear Dr. Ola? It might just be me then.
You're very quiet, Dr. Ola.
Do the volume.
Yeah, if you come on the video, Dr. Ola, and
yes.
just talk into the microphone, into that.
Hello, can you hear me?
Yeah, it's better now.
Okay.
So I just wanted to demonstrate an approach. So Dr. Ola is a lovely colleague of mine. I just wanted to, Dr. Ola, we can see your just your head at the moment. Yeah. But if you feel that it's better to just talk and you'll be clearer, then that's fine. It is what it is. You know, it's just a, you know, joys of virtual. So I just wanted to demonstrate the approach, which I'm sure you all do very well, but I just wanted to understand the difference. So Dr. Ola is going to be the patient. I'm going to be the doctor. Okay. So this is the first sort of role play. Okay. So hi, Mr. Ola, how are you?
Good afternoon. I'm very fine, doctor.
Okay, Mr. Ola, I'm calling from the practice, and I just noticed that you haven't had your blood pressure tablet. It's really important you take it because it can cause heart attack and stroke. So what I'm going to do is I'm going to send the prescription to the chemist, and I'd like you to take it. And yeah, any questions?
Do I have to take it for life? Can't I stop taking it when my pressure is better?
So Dr. Ola, no, you just have to take it. You just have to take it. It's really important you take it. Otherwise, you'll end up having a stroke. Yeah? Okay. All right. So I'll send the prescription. Thank you very much. Okay. So that's consultation A. Okay. We go to consultation B. Okay. Hi there. Is that Dr. Ola?
Oh, good afternoon, doctor.
Hello, doctor. So, doctor, I'm calling from the practice, and I was just looking at and tidying up some of the prescriptions on your books, and I can see that you haven't had your blood pressure tablet for a while. And sometimes that can happen if the chemist hasn't delivered it. Sometimes it can happen because you've lost the prescription, but I noticed you haven't really used it for 6 months. Is that something I can discuss with you?
Yeah, I don't like the tablet. It causes my leg to get big and I can't wear my shoes.
Oh, I'm so sorry to hear that. Okay. How long ago did you start the medication, Dr. Ola?
About 7, 8 months ago.
And did the swelling come from then, that time?
Yes. Yes.
Ah, and the doctor or the person that started it, did they explain what the tablets can do?
Maybe. I'm not too sure.
Okay. Would you like me to go back and just go back perhaps just to the basics of blood pressure and why it's important to control and what it can do? Would that be something you'd be happy to discuss today?
Yes, please. I would be grateful.
Okay, thank you. So I'm going to stop this consultation here as a consultation be. Thank you, Dr. Ola. So what do you see is different about the approach? What do you guys notice is the difference between the two consultations here? Anyone, type in if you don't want to speak. Okay, Gabel, which one do you think is more personalized? Second one. Okay, Gabel, do you want to, given that you've answered, can you tell me what is it about the second consultation that is making it a bit more personalized?
So in the second consultation, you took a patient-friendly approach where you didn't want to just force the medication onto him, but got the answers from himself and he actually wanted the help. You know, he said the words out of his own mouth, so that was better coming from him. And you said that you're happy to explain it, and you didn't sort of impose anything on him as to why he wasn't taking the medication. But you gave him options where you said, you know, it could be other reasons that are not related to you. So he had a way out and he felt comfortable talking to you in that manner and just saying, okay, yeah, it could be this. So
absolutely. Yeah. No, thank you, Gabel. That's brilliant. And I wanted to demonstrate the concept of doctor-led directed consultation, which was the first one. I want you to take this. I'm the doctor, you are the patient, and you take this because I tell you to take that. And actually, I haven't stopped to think, did this patient have side effects? This patient's understanding of blood pressure there? I haven't bothered because all this patient will do, yeah, thank you, doctor, put the phone down and carry on with his life, not taking the medication. Whereas with the second consultation, it makes it more personalized because I'm now thinking, actually, what is it that you need from me to be able to take the medication? Yeah, and that's what you need to get out. So the concept of non-compliance, usually in my experience, isn't because the patient thinks nothing wrong with them, is because we as clinicians haven't really driven, not in every patient and every case, but by and large, we haven't really driven and used the right language or understood the health understanding of patient really. What is it from their perspective? And I was going to do another example, but I'm not going to now, where a patient, this is real, where a patient I rang 2 days ago for cholesterol, finding out why he hadn't taken cholesterol tablet. He told me, well, I took it for 6 months and then I had my result. I rang the surgery and they said the results are normal. So I stopped taking it because it's gone back to normal. So this is where, and unless I got that out of him, I wouldn't have really understood, actually, no, really, I need to go back to basics with him and explain this is for life. Yeah. So it's really important when you speak to the patients about non-compliance is understanding their beliefs, understanding their views on why they're not taking medication, and seeing where the support can be given. Patients have various reasons. It could be that I'm asking them to take every morning at 9 o'clock, or that's what in their head, but actually 8 o'clock, they've got to dress the kids, they've got to drop them. They just cannot remember to do it. So unless I know that's happening, I can't say to them, actually, no, you can take it in the evening as well. Or, you can take it with your lunchtime at work. So that's where the personalization comes in, that you are using the guidelines to fit the patient's needs, essentially, rather than actually, taking the guidelines and saying, well, let's put the patient onto there and that's it. Yeah. So I hope you got that sort of difference. I just wanted you to demonstrate that, but thank you. And thank you, Gabble, for that feedback. Next slide, please, Paul. So Paul, just the next slide. I think it's just the same thing. Okay, so I just wanted to summarize what we've discussed so far, and then I've got some case studies. So in the green group, the expectation is the practice will contact the patient, or you will contact each, as I said, each practice will have their own way. The patient will be either given an AccuRx message to say your annual health blood pressure check is due. You will need to do home blood pressure monitor, or whatever, come to the pod, or you come to the clinic. And I'm hoping you would have read coded, and it's really important you read code if they do blood pressure at home, because actually for the practice it would be really easy to pick that read code for next time to say, actually, this is not the patient that we need to bring in, we can do this remotely. So it would really be helpful. You tell them that actually the blood, apart from the blood pressure, then the annual health check would include smoking, etc., etc. You can use an AccuRx to get that basic details. This is where I say a combination and a hybrid model of face-to-face remote consultations would do. So and this is what we do at our practice. We send that AccuRx message that will have details like, do you smoke, drink, all the basic bits we need for the annual health check. That's read coded. I know now that the patient records at home. I then send them along with that a home monitor sheet, which has got blood pressure readings that the patient can record and send back through AccuRx to us, for us to then work out the average. So this is the next line. How do you check the blood pressure? Do you record it at home? Check, once you get the readings, you'd work out the average. If the average is under control, you arrange the blood's ACR, you offer lifestyle, you can send the video that I've just shown you. You can check compliance and side effect through the through your AccuRx message, or looking at the prescription dispensing. So if you see that they had gaps, you want to have a call with this patient. But if you see actually they're really good, they keep requesting every 3 months, it's fine. Side effects, again, you can AccuRx. So ACR is proteins, Gabble, in the urine. We mentioned about the end organ damage to look at protein. So ACR or PCR for ACR for diabetic, but I'm not going to go into detail. It's just basically looking for proteins in the urine. Yeah. And actually, if you look at that green patient, literally most of the things you can do remotely, particularly if the patient's got blood pressure home, or if you've got a pod in the surgery where the patient can come anytime when the surgery is open, do it, and you check it and it's all clear, file it. That's it. That's the end of it. Yeah. So actually, most of the things can be done remotely on the low risk pathway. There will be a few patients that will require the conversation about compliance, side effects. There'll be other patients who are getting other symptoms that you need to hear and forward to the GP. But actually, most of the work in the green group could be done remotely. Yeah. I hope that's clear. Now, I've put this last bit down, that if they're in clinics and for people that have got the skills, make sure you check their pulse, because again, it's common for, it's a common problem, irregular pulse, which is often not picked up, and the time it's picked up, it's too late when they've stroked. So you need to, for the clinicians that are there that don't know, make sure you get that, acquire that skill of checking the pulse. They are looking at some digital ways of doing it in the practices where you've got these sort of apps where that would tell you if there are, it's called Fibri check or something, where patients can, you can just scan it and check whether they are an AF or not. And again, as I mentioned, remember, if they've got irregular pulse, do the, the manual blood pressure, not the electronic one. Okay, so that's the summary really of hour and a half. But I'm just going to move on to the next slide quite quickly, because I do want to give people time to ask me questions. But Paul, can I just go to the next slide and I'll come back to questions, because I want to just see if people are fresh in their head, if they're able to apply the case studies. And again, speak, chat, whatever you want to do, please do. Okay. So I've got this 58-year-old man in the surgery for blood pressure check. Okay, so he's attending surgery. His blood pressure is 150/90. Last year when he attended, the blood pressure was 145/88. Okay, he's on Ramipril 5 mg, which is a blood pressure tablet. And just to remind the people that are not sort of clinical clinicians here, that this is a tablet that can cause cough. Yeah, just as a reminder, but it's got nothing to do with the case study. But I thought I'd just remind you and use that opportunity. So 58, first of all, is he on target? Do you remember the target levels?
He is on the second target level, 150.
Yes. So absolutely. Okay. So what should be the target? Well done. Well done, Gavel.
Should be 140.
Less than 140.
Yeah.
90. Yeah. Do you remember this target is for 80 plus?
80 plus, yeah.
Okay. Under 80 should be less than that. Okay. And that's why I said clinic. I didn't want to confuse you about home, etc. So I said in clinic. All right. So what else would you check? He's come for his annual review. So what else would you check?
QRIS template on EMIS.
Way, well done. Okay, excellent, Olivia. Yeah, well done, Gavel. So you've got bloods, ECG, urine. So ABPM. Okay, BMI. So yeah, compliance, fantastic, brilliant. I really wanted to get that QRIS, and really well done. I'm really pleased about that. So Olivia, just going back to your point about ABPI, you wouldn't necessarily do ABPI in this situation unless you suspect this patient's got a white coat hypertension, in which case you'll ask him to do home blood pressure monitors if he can afford a blood pressure monitor. If he can't, then you've got no choice but to send him for ambulatory pressure. But by and large, patients have, and actually a lot of practice and PCNs have been given blood pressure monitors for free now. So check with your practices where those monitors are that you can loan. Obviously, the fear is once you've loaned, it'll never come back. But yeah, it is what it is. So no, you won't necessarily do this, because just remember, Olivia, for ABPM and home blood pressure monitor is at diagnosis. Okay, when you're not clear at diagnosis, that is it genuinely blood pressure, you would then send them. But I would certainly send some people if I suspect that they've got white coat, or do you know, remember I said masked blood pressure, that actually clinic blood pressure is normal, but when they go out and about, it goes high. Okay, so what would your next steps be? So you've done your annual check, you know he's not on target. What would you do?
Set a new target.
So his blood pressure is high.
Okay, yeah. Oh, yeah.
What would you do? Review medication, Colleen. Well done, Colleen. Yeah, I know, Olivia, that is really good. So I would send that leaflet and booklet, really, really good. But Colleen, you're absolutely right. I would go to the GP, tell them, because he's now tipping into the other category, isn't he? He's tipping into priority 2. So what you need to do is to go ask your PCNs and practice the system. So in my practice, my team will come to me and say, blood pressure is high. I would increase the medication there, and then I want them to remain in that green zone. Yeah.
The reason why you would change it, is that because he's already on medication?
I won't change it. I would increase the Ramipril dose.
Okay. Yeah, no, you would increase it. But in terms of, obviously, so this is a gentleman, you've got one reading of a blood pressure check. Would you not check it for 4 days or 7 days before you make any changes?
So remember the clinic blood pressure readings, you can just have one.
Okay.
Yeah, so it's high. And but if he comes and tells you, you know, my wife died last week, or you know, I've got financial issues, and if you really feel, is the stress driving this, that's when you can think, actually, I need to think outside the guidelines box. And actually, in this patient, the blood pressure was okay last year, is gone up. Is it just age, or is it that stress? If he says to you, absolutely everything is normal, not stressed out, nothing has changed, that's the reading. And clinic blood pressure readings, every time you do clinic blood pressure reading, at that time you'll do 3 readings. So all the clinician will do 3 readings at the same time and take the best of the 3 readings.
Sure.
Okay, so you don't have to send him away and come back. He's not on target. He needs to be on target. So you speak to the clinician, optimize the medication so he stays in that green zone. You don't have to push him over to the other zone.
Okay, got it.
Okay. Yeah, Kaleem, well done. Kaleem, you didn't need to be here. You trained. Next slide, please. Yeah, thank you, Paul. Okay, so this is some basic O-level maths. Okay, I don't want you to work it out. Just tell me the formula. How would you work the average? So this is an 82-year-old who sent his blood pressure readings to you, and he's done these readings. He's done 4 readings. And you remember, I said, if they've known hypertension, minimum is 4 days, but ideally 7 days. So he sent 4. I'll be happy with those. So how would you work out the average reading? Anyone?
You add the top 4 and you divide it by 4, and then you add the bottom 4 and divide it by 4.
Simple. So you just do the average of systolic, average of diastolic. He's 82. So what should his target be?
82. It's gone out my brain.
No, that's fine. Just remember the figures. I know this is why I said the numbers are sometimes really hard, and I'm going to produce a little sort of a booklet that would you could just follow, because so it's 150, 90, less than, yeah.
Okay, yeah.
Yes. So based on that, we think it might just be over, right? Just be systolically over. But the point was, how do you calculate? That was the idea of the slide. Yeah, you know how to calculate. Okay. Yeah, Azra, thank you. That's great. Next slide, please. And Kubra, you got that as well. Well done. Okay, so this is a 66-year-old, and he's got me the following home blood pressure monitor. Now remember, home blood pressure is 5 less than the normal one. Yeah. Home average is 132/78, and cholesterol is 5.9. I haven't given you much information, but what would you do? Anyone? Okay, Kaleem, diet, lifestyle, you absolutely have to address. Absolutely, Kubra. Looking at that cholesterol, you work out a Q risk if he's not on a statin already. So if you've done a he's already on a cholesterol tablet, then you don't necessarily need to do a Q risk, okay? Except that if he's on a statin, that is slightly high reading, and you'll need to adjust the lifestyle. You'll need to speak to him about his diet, etc. Okay? Anything else would you do? What about the target? Is he on target? So remember, 66, 140, 90, less. And you take 5 off if there's home or ambulatory. Yeah, so 135, 85, it should be. Yeah. Honestly, you don't have to remember all this, because I'm going to try and produce this weekend a simple chart, because I need to do it for my HC as well, that you just have to look at. It'll be easy to follow. And once you've done it for a lot of patients, it will just be you'll automatically just remember those. But the point of this slide really was that you calculate the Q risk, because if you've got a cholesterol result here, and they are blood pressure wise, they're on target, and it's not on a statin that then you start a statin, in which case you need to know what your local process is. Where do you go, which consultant, which team do you go to start a statin? It could be a pharmacist, it could be a clinician, whoever, but that's something bespoke to your own PCN or practice. Next slide, please. Okay. Right, case study 4, you've got a 72-year-old, blood pressure 170/92. He tells you he's not taking his medication. What can we do?
Personalized care. You need to find out why.
Yeah, well done, Gabble. Well done. You should be a HCA, Gabble. You're a health and wellbeing coach, right?
I'm a care coordinator.
Care coordinator, okay. No, well done. You've done really well. So actually, this is all about personalization. It's asking why what's causing the problem? Does he understand? Revisiting some of the targets, revisit the reason. How can you support them? Are they worried about the side effects? Who can they speak to? So it's all those things about non-compliance, yeah, rather than just saying non-compliant, go away, that's it. You need to know why they're non-compliant, and often there will be a reason there. And I've heard various reasons. I've heard you know, my mum was on this tablet and she had a stroke. Well, actually, no, your mum had a stroke because her blood pressure was high. So it's all those really weird and wonderful health beliefs that patients hold that you need to start challenging. And a lot of them, you've got to chip away. You've got to be the woodpecker there. Okay, next slide, please, Paul. Okay, so I think it's probably last but one. Right, now, 52-year-old, his blood pressure is 200/120. He's got a headache. What do you do? I really hope you get this right.
It's too high, and he's got a headache, so he needs to be seen soon because over 180, 120.
Yeah, exactly. Remember, the only thing that I wanted to remember out of this was actually you've got a patient with a symptom. Yeah, absolutely. Well, A&E, fine. And I'll speak to your GPs locally, whatever your pathways are, but he needs attention now. He needs to go to the hospital, however you send him.
Would you ask this patient if it's when he suddenly gets up, if he gets a headache and dizziness and other symptoms as well?
No, so, well, you could absolutely ask, but if this patient's blood pressure is so high and he's telling you he's got a headache, I'm not going to bother sitting and asking any other questions, whether the fundus shows anything or the urine's showing anything. No, this is too high. You need help now. Yeah. And so ECG, Kaleem, ECG, no. So in this case, I'm not sure how the ECG will actually help you, Kaleem, because the ECG would help you if you feel that the pulse is irregular on top of the high blood pressure, then absolutely. Now, Azra, if they're asymptomatic and they've got no end organ damage, all right? So when I say red flags, these are patients only with really high blood pressure with symptoms. Without symptoms, you don't have to send to A&E, but you as clinicians need to speak to your GP, because what you need to do is to look at the end organ, and that's when, Kaleem, you would need a ECG. So you need to see, has the blood pressure damaged their heart? Have they got protein in the urine? Have they got, you know, fundus problems? In which case he needs to go in. All right. So that's when you would do ECG. But symptomatic patient, don't bother about doing anything. You need to send them in. Asymptomatic high blood pressure, you could do sort of, and actually, to be honest, I haven't yet to see a patient with such a high blood pressure who doesn't have some end organ damage. So by and large, most of them have got something that will prompt you to send them to the hospital. But equally, you don't have to. You could, if they're asymptomatic, start them on medication. But as far as you guys are concerned, in the low risk, you need to speak to your GP and follow the processes that are there. Okay. But that was a brilliant question, actually, and one I wanted to cover and I forgot. So thank you for reminding that. So the next slide, please. And this is the last one you would be pleased to hear. So now we've got a 49-year-old with moderate learning disability. Now he's got a blood pressure of 140/80, BMI of 32, and a cholesterol of 5.8. Okay. Now, mind you, he's got LD. So you need to make sure that whatever advice you give has got reasonable adjustments in it. So, you know, you don't tell them actually go and run a mile a day or don't eat XYZ, because actually it's not something that's not a personalized approach at all. Okay. So, you know, theory wise, is the blood pressure on target? He's 49. Not on target blood pressure?
He is, right? Because he's under, it's 500.
Yeah.
He's under.
Clean, why do you say no? Why is blood pressure not on target? His blood pressure, so it's, remember what we said, the targets over 80 and under 80s. Yeah, so he is on target. Yeah, absolutely. He's on target. BMI, absolutely high. Yeah. So you would give lifestyle dietary advice, but the real thing I wanted you to take home from this, that there are community learning disability nurses. So if you feel that you are having problems communicating, or they have behavioral issues such that they won't be able to follow any of those advice, or the carers need support, please get in touch with your community CLDT team. They are in the process of updating the contact list, which I will. Paul, do you want to just remind me as an action there? I will share out when it's done. And their role really is to support practices and, more importantly, the patients' needs that you're struggling with. So if you've got patients that have got behavioral issues or sort of dietary issues that you can't sort out, or you can't even communicate the risk to, then that's when they come in handy. So do be aware that there is support and help. And what we are trying to work through the LD sort of pathways is to create reasonably adjusted pathways for all the social activities. So trying to create something, because most of the parents, you cannot say to a parent with motor LD, actually go down to the gym or go down to the swimming pool, because actually it's not something that they're able to do, because they need a carer to take them down. And it is just more, you know, wider than just that advice. You need to liaise with a carer, social services, to see, does their package include this? You know, because otherwise they'll have to relook at the package, etc. So it's a bit more complicated than you and I can deal with, and it needs to be a multi-professional, multidisciplinary approach. And that was the point of this slide, that actually it needs to be, you cannot make that decision on your own. If you've got a struggle, mild LD usually okay, but moderate and severe LD, I think you need to be, you need to try and get that support from the community teams to help. Okay. So I think that was the last slide. So questions now. Okay, questions and any point of clarification, anything that you want me to go back on. So I've got where are the nurses based, Sudeep? So they are based in near Barkingside somewhere. So each area has got a CLDT. They've got community learning disability teams. So there's one team in Redbridge, one in Havering, one in BND. And they've got nurses that are aligned to the PCNs, or to the PCNs actually now. And that's what they're in the process of assigning at the moment. So I will have more details of that, hopefully in the next couple of weeks, which I can absolutely share with all the PCN CDs. Yeah. And then I've got a question here. Repeat how you go from home blood pressure measuring to ambulatory, and what is ambulatory? Okay, sure. So when you diagnose, so if you get a patient who hasn't got blood pressure, and you've seen them for whatever reason, and you know, you just happen to do the blood pressure, and the blood pressure is high, okay, what the guidance is that if the blood pressure is anything between 140-90, so it's in that stage 1 and 2 range, then they can either do home blood pressure or ambulatory blood pressure to make a diagnosis. So for diagnosis, this is important that you refer them for home or ambulatory blood pressure. Ambulatory blood pressure essentially means that the patient doesn't have a home blood pressure monitor. You've got to refer them to have the blood pressure monitor done to a, I think it's done by InHealth at the moment, or one of the companies, but there's a form that the GPs can fill out and refer. Patient gets attached to a blood pressure monitor for 24 hours. And then they're going to have to go and deposit it back to this place wherever they picked it up from. And then 3 or 4 days later, or sometimes longer, you get a report with an average blood pressure. And if the average blood pressure is over 140-90, then they've got blood pressure essentially. So that's for diagnoses. What I was saying about the annual check is that if the patient has got home monitor, then you rely on those readings. You just send them through AccuRx a chart where they can record the reading, and you then work out the average. Yeah. So ambulatory is the same as 24 hours. Absolutely. Yeah. So, but for diagnosis, you need to refer for home or ambulatory. Okay. It's not just clinic, but for annual reviews, you can then rely on clinic, home. And if you feel they've got white coat, because as I said, if they've got bereavement or some other stresses in life, and you feel actually, excuse me, that they've actually got, you know, so far they've had perfect blood pressure, but suddenly it's gone up and they tell you, oh my God, I've lost my job or whatever, you think actually there might be a white coat syndrome here, in which case you can then refer them for ambulatory blood pressure. If they have home blood pressure monitor, so again, for diagnosis, no. And for monitoring, no. If they've got home blood pressure monitoring, no, they do not need to be referred. But for diagnoses, they need 7 days for sure. For if you're monitoring, it's minimum 4 days, but could be 7, between 4 and 7 days. Yeah. And I'm going to try and just I'm going to try and create something which would be simple to read for everyone, that you could then just adopt or change according to your PCNs. So I'm going to try and work that up over the weekend. I've got to do it for my HCA, so I'll just share that around as well. So again, just repeating, if you've got a patient who you think is newly diagnosed and the clinic blood pressure is over 150/90, you think likely blood pressure, okay? You would do left and right blood pressure. You would do sitting and standing blood pressure. You would check the pulse to make sure that actually you don't need to do a pump up the manual blood pressure, okay? And you shouldn't really be doing this in the green group, because this diagnosis really should be by a clinician, because you need to examine the heart, you need to do a lot more really, okay? But I'm just saying, in case you and just so you know what happens to these patients. But the ones you will be dealing with will be the ones that would be coming for the annual health reviews, in which case you can do a clinic, you can do ambulatory blood pressure, or you can do home blood pressure, but you can do it for 4 days, the home blood pressure monitor. I hope that's clear. Yeah.
Just a question on what you just said last. So the bit was just if it's a new reading and it's 150/90, then you have to do all of those, but it's more checks to be done.
No, Gabriel. So new diagnoses.
Okay, fine. New diagnosis.
So it's first ever time you're diagnosing somebody. NICE is saying you've got to make sure you just don't rely on the clinic reading.
Okay.
You get them to do an average reading, either ambulatory or home.
Okay. No, I meant, you know, when you said you've got to do both hands, standing, sitting, all of that.
At diagnosis only. Because what you do is then you tell the patient, actually, blood pressure is measured better on your left arm. So every time you come, make sure you take your left arm out. Okay. Or you will say, actually, when you come for your blood pressure, your irregular pulse. So please make sure the clinician does a manual check, not an electronic one. And don't do home blood pressure monitors unless you've got a nurse as a daughter or son or whatever that can do it for you. Okay. So that's where that's what you tell the patient at diagnosis. At diagnosis. Okay. Yeah. And that's what something at annual review, Gabriel, that you might want to speak to the patient, say which arm is better. Okay. Or if they've got postural drop, you know, you said low blood pressure. If they've got that postural drop, then you do it standing. Okay. So my standard question to patient is, how do you like to do the blood pressure? Which arm would you stand? And if they don't know, then I repeat that because they've never been told that. And then I will tell next time you come, your blood pressure should always be checked standing. And we need to use a manual blood pressure or if nothing, I'd say any arm if it's equal, etc. And you won't find many of those patients actually. Usually it's okay. It's roughly the same, really. Fine. Yeah, I know it's confusing. It is confusing, and a lot of GP trainees as well take a while to really grasp the concept. You know, because there's so many readings to remember. Yeah. So much to remember. But as I said, if you remember that, you know, 180, the high risk ones. And you remember for your green zone, you want people to be less than 140/90. That is what you need. You want people to be Q risk and on a statin. Yeah. Just one other question. There was 2 case studies where you had the cholesterol and people in the chat put up to do the Q risk or you explained to do that. So is that something that we should look out for when we're doing the annual, just because we're dealing with just the hypertension? Should we also look at the BMI and cholesterol at that point? Because from what we were discussing within our PCN, we were just going to look at the hypertension, just the readings themselves. So I mean, the proactive pathway, as I explained, is not just blood pressure. And actually, a blood pressure without a cholesterol or a BMI, you haven't really done justice to the patient, because it's reducing. The reason why we are doing or controlling blood pressure is to reduce cardiovascular risk. So in order to reduce cardiovascular, it's not just blood pressure, it's reducing the weight and cholesterol. And actually, as I said, it's so easy. And I don't know if I can share so the QRisk template on the EMIS. Let me try and see if I can bring out Mickey Mouse, given that I've got 10 minutes. Do you know, I have never finished a webinar on time. So actually, Paul, I've done really well today, isn't it?
You haven't finished yet.
He says, yeah. It's usually the questions that I just carry on and on and on, isn't it? We actually had a patient, Mickey Mouse, you know, it's funny. So I keep showing his notes, so make sure I show the Florida one. Okay, Paul, how do I share? Share screen. Share screen. Share screen. I've got that. Yeah, I've got that. Yeah. So can everyone see this? Can people see the screen, Mickey Mouse?
Yeah.
So this is EMIS. So literally you have to open the consultation. And I do apologize for people that actually are not working with EMIS. You literally open the consultation. God, I would have to shut that. Kaleem, I should have asked you to do this because you're a pro there, isn't it? So you literally open the consultation and there is a box here. You run the template and there's a QRisk template here. It's obviously saved because obviously I use it a lot. And all you need to do is calculate. Yeah. Obviously in this patient, because Mickey Mouse is only 9-year-old, it's not going to calculate. It's not going to give me a figure, but actually it gives you the figure here.
Okay. And
then you save the template. And that means it's saved here. And it tells you the QRisk is whatever. Yeah. And then all you do is to look and I'm assuming that you would have looked and seen, is he on a statin? If he's on a statin already, then you don't even bother doing anything. Okay, now I need to unshare. That's going to be a challenge in itself.
Thank you.
No, that's fine. Paul, how do I unshare this? I can't even open this properly.
So if you put your cursor at the top of the screen.
I have.
Okay, I think I might be able to do it.
Can you? That'd be great. Thank you. Thank you, Paul. Okay, so question time. And you can break my record of running on time or not. It doesn't matter to me, but I'm just going to pick up some of the things here. So when is it better to do standing over sitting blood pressure? The only time I would do that, as I mentioned, was that if the patient has got symptoms. If the patient tells you, as soon as I get up, I start feeling dizzy, it could be that they've got what we call as postural hypertension, in which case you need to do standing and sitting. You always do it at diagnosis, always. Because that, as I said, if there is a drop of more than 20 and 30 difference between standing and sitting, so top 20 and bottom 10, then you go for the one that has got the higher blood pressure. So you do a standing one, essentially. And then when else would you do standing over sitting? In all patients with diabetes and all patients over 80, because I told you about the nerves. So when I stand up, my vagus nerve is, if it's working properly, what it would do is it would adjust my blood pressure to what I need so I don't fall. However, if there is a problem with the nerve, you know, because of diabetes, nerve damage or whatever, then that mechanism is damaged and my blood pressure isn't adjusted as quickly as it should. And hence I fall and I've got postural drop. So as soon as I get up, it drops, whereas actually shouldn't drop. Is that clear, Kubra? So diabetics, patients with symptoms, anyone over the age of 80, I would do sitting and standing. Keep bringing those questions. Any other questions? So it's actually really straightforward in terms of how you would manage the low risk pathway. But, you know, I would say that speak to your PCNs, because there's no point you just doing blood pressures. I'm not sure how that's going to help if you're not going to do an annual review. But I don't want to interfere in each PCN. The expectation of the framework, and Paul, I don't know if you can take it back to the framework slide for me, if possible, is exactly what I said, is going through the annual checks, doing the Q risk, and working out if they need to be moved or do they need anything else. Because it's not just about blood pressure, it's the cardiovascular risk. And back, I think, Paul, it was third or fourth slide, I can't remember. Yeah, that the next one, Paul. Oh. Yeah, that green one, Paul, just before, yeah. So you see that bit that's on the left, the green bit, it actually tells you to do a lot more than just blood pressure. It's giving you the target and it's telling you exactly what to do. In fact, actually, I think I would just cut and paste this and give it to people. You don't need anything else really, do you? Because this is the pathway. I'm hoping, you know, PCN would have worked out the patients and then they will start booking you, in which case you do all this bit that's on the green bit, including moving on to doing the Q risk and signposting, etc. Because this is the main piece of work really. It's easy just to increase and decrease the medication, but this is the crux really of patients being compliant and making sure they're taking the medication issues, side effects, etc. So that is the main thing. Okay. Any further questions, Guy, before we stop? Kubra, was that clear in terms of the when you do sitting and standing blood pressure?
Hi, yeah, that was clear. I have one question. You said something about read coding something before to help. What did you have to read code?
So, you know, how would you know if the patient, so for example, I give you a list of 100 patients and I say to you, Kubra, you know, ring them up and, you know, work out what they need. Well, actually, wouldn't it be better if you'd read coded that actually out of the 100, 70 patients had home blood pressure monitor. So blood pressure done by patient at home. That's what you read code. So when you do a search, what you could do then is to those 70 patients, send an AccuRx, say, you've got a blood pressure machine at home, time for your annual review. Please do blood test, urine test, send me the next 4 days or 5 or 7 days, whatever you prefer. And here's a sheet to record it. And this is the link to send it back through AccuRx. Do you see what I mean? So you're recording that the patient is doing the blood pressure at home.
Yeah, that's fine. And just one more thing, you know, with at diagnosis of hypertension, you mentioned to do an ECG every time. I'm not, if it's, say for example, we're doing a review after they're diagnosed already, and you notice they haven't had an ECG already, is it worth sending them? So they've got to have at least one, right? And then after that, it doesn't matter? Yeah, so, well, it matters as much as if you see that they've got symptoms. So the reason why we're doing the ECG is to check for end organ damage, right? To see if they've got, the heart is becoming bigger, right? Yeah. So you, therefore you need to have a baseline. If they've never had it, NICE is not recommending anything, except that they're saying they should have a baseline. So as far as I'm concerned, that is their baseline because I've only just recognized that they don't have one. Correct? So if they then in future, you don't have to do an ECG every year, except if they get symptoms. If they start saying to you, we're breathless, we're getting a bit of ankle swelling, then you're thinking there's something going on. Then you start doing ECG. The other reason for doing ECG at diagnosis is to look for secondary causes. Remember I said to you, primary and secondary causes. The secondary causes, which I haven't done for this group, it'll be too complicated really, is one of the ones is what we call as HOCM. So it's cardiomyopathies, which is where there's a family history.
And the way to diagnose is through ECG. One of the ways is through ECG. When you'll see certain changes in the ventricles, you may think actually there may be a problem here. Yeah, because that could be a presenting, hypertension could be a presenting symptom. So definitely a diagnosis. If you haven't had a baseline, do an ECG, but you don't have to do it every year. Is that clear, Kubra?
Okay, perfect. Thank you. Yep, that is.
So, I mean, Steve, the searches and framework, the KEG is working with the PCNs. I mean, I've got the searches I've got them saved on the on our Kaleem. I don't know if you've got them. So searches are there, so I can't say where your PCN or practice is with that. It's something I think if you take it with Sonia, I don't know if Sonia's on this call, she should be able to work with UCLP partners and CCG to try and get that search down to your systems, because unless you know which patients to call and which patients are in which group, where are you going to start?
Yeah, I came across the searches independently. I went on a UCLP webinar, so I've downloaded them, but we haven't had the conversation from the PCN to say we definitely have to use them. I personally think they're great, but the other pharmacists are not necessarily using them. So it's more of a, if it is now the official way to do it, then I can cascade that back to my colleagues.
Yeah, I mean, Sandeep, it's a discussion definitely to be had. What is the approach the PCN is taking? Because it is a PCN piece of work. There would be sort of changes within the practices on how they're doing it, but actually there needs to be a PCN principle that you follow. And the basic thing to start with is the searches. Yeah. But yeah, it'd be great if you could take it back to Sonia and see how that's been cascaded down, or what is that approach.
Okay, perfect. I'll do that. Thank you.
But no, thank you for bringing that up. That's brilliant. Right. Anyone for any more? Otherwise, I can officially end the webinar and break my record. That's amazing.
Probably worth saying in the last minute and a half, everyone will have heard lots of advice around kind of signposting and encouraging people to change lifestyle behavior. So we've made available to everyone who's part of this proactive care pilot. So we have making every contact count training available, motivational interviewing, and also for some of the other kind of bits of work you're doing, video group consultations. So all of the registration, the links to access that training is all available through the flyers that were sent out. If you can't access those, just come and talk to me directly, and we'll make sure that you get linked into those.
And Paul, that's, I mean, it's a really good point. Actually, a lot of patients, the group consultation, I think that would be a really good skill to have. So if you people are interested, speak to Sonia and see if we can actually plug you into the group consultation skills, where you can actually give lifestyle advice to a group of patients, you know, a group of hypertensives, because it's similar advice really. So yeah, just if anybody needs, do we have the offer on motivational interviewing as well still, Paul? Is that still going? Yeah. So there is it a course, or? It's
a, I think it's a couple of hours session or a few hours session. The making every contact count is 2 hours, and if you need further kind of more advanced, then we can make that available too. Okay, so if anyone wants any information, Paul, do you want to just put your CPEN details? You can contact Paul for motivational interview training or MEC training or anything else. That would be really helpful. But lovely bunch. Thank you for all the questions. Comments that were coming in, and I think you guys are already there. You've done, the responses were amazing, really amazing. So well done, and thank you for all you're doing. But do contact us if you need further training. I will be running these sessions for other groups. If you feel that you haven't really completely grasped the concept, just come and join the other. Except that you might get bored and listening to the whole 2 hours again. We'll share the slides. And we'll post once this recording is uploaded, we'll share that the link for that as well, so you can access that whenever you need to.
Okay, lovely people. Enjoy the evening. Great seeing you all, and keep on with the good work.
Thank you. Thank you for
Thank you, everyone.
Thank you. Bye, guys.
Thank you.